So this first slide is for Dr. Quinn's benefit. So this is the logo of the course, the Brooklyn Bridge. And it's connecting science and medicine. And the folks here have heard me talk about this too many times, but I explain why we put this in, beside the fact that it was taken by my grandfather. Now, so this is the organism which, when I was a medical student, I saw that in a stains section and decided I want to be a microbiologist. I didn't. I wanted to became a liver doctor, but that's sort of become microbiology these days too. So today's topic is self-evident. There was a time when the great parasitic diseases of man were looked upon as the great neglected diseases, was the phrase. Things like malaria, schistosomiasis, a whole range of parasitic diseases which affect millions and millions of people. I don't think that sexually transmitted diseases was in that official list, although some of them may have been. I don't think so. But this is a group of diseases that have been with us for Lord knows how long, and it's a panorama that keeps changing. Amazingly enough, the pathology changes. I'd like to say a word about that. And with it, the severity. Treatment has dramatically changed, and so has epidemiology. And although we think that society has advanced in many ways, through communication, electronics, and everything else, there are some areas that sometimes defy our cultural sensitivities, if that's the politically correct way to put it, and they get neglected. And I wonder, we'll find out whether our speakers today consider that the sexually transmitted diseases are, we're leaving out for a moment HIV and HBV and HCV, whether those diseases are great neglected, and if so, why? So let me give you a brief example of what I think of along this changing panorama. Let's talk for a minute about syphilis. You know, it's been blamed on every country in Europe. It was thought to be imported from the New World, which maybe it has been, I don't know. The French called it the Italian disease, the Italians called it the Spanish disease, and the Spanish called it the French disease. But it seems to perhaps have come from the New World, although where it sprung from there is not quite so clear. But the point is, with its introduction into Europe and as population density increased, syphilis became widespread, was highly infectious, and was severe, and killed people. It led through different stages, which perhaps we'll hear a bit about today, and at least in the early stages, was very infectious. But then in late stages, it wasn't so much infectious, probably not at all, but it was a disease involving the big blood vessels, particularly the aorta, which ballooned out, something called an aneurysm, and killed people, or the central nervous system, where people lost their minds. They were, I remember being shown in medical school, there was a man who was convinced he was Napoleon Bonaparte, and that was presented to us as central nervous system general paresis and other neurologic abnormalities. Now those things, I think, have largely disappeared, but we'll hear. It was said, if you know syphilis, you know medicine, or if you know tuberculosis, you know medicine. The great pretender. Because it literally could affect any organ and present in a wide variety of spectra. And in those days, pre-scans and pre-SMA-16s and all sorts of other diagnostic stuff, you really had to use your head more, I think, than the lab sheet, and it could be very difficult to know what one was dealing with. There was no real treatment for it, although it was shown that heavy metals could inhibit the treponema. And there was, I don't know where it came from, this notion that you spent one night with Venus and a lifetime with Mercury. Mercury was quite toxic. Medicine's a funny thing. Sometimes bad things, things are done for good reasons, but what comes out of it has nothing to do with anything else. For example, the observation that mercury was a diuretic, now we know how that works, came about through the treatment of syphilitic patients with mercury. They diuresed, had nothing to do with an effect on the treponema. And then the amazing story, one of the great dramas of all medicine, and those of you who like to read medical history, whether it's in the form of a novel or the real thing, you should read about Paul Ehrlich, a famous physician, chemist. I think he was a chemist only. I don't think he was a physician, but it didn't matter in those days. He won the Nobel Prize for his concept of the magic bullet. And this was apparently the first time anyone had the idea that you could take something and modify it so it would kill the offending organism but not affect the host. And the organism he was interested in was this treponema. And so he could see it, he could give it to rabbits, they could propagate it, he had models he could work with, and they knew that heavy metals like mercury would kill the organism, but the trouble is it also killed the host, or the cells. And they found that arsenic also did the same thing. So he said, maybe I can modify arsenic chemically so that we targeted a magic bullet to the organism and not to the host. 606 compounds later, he and his Japanese colleague, Tata, I think was his name, came up with the compound arsphenamine, or an organic arsenical, which when given to syphilitic patients, it was like day and night. And arsphenamine was the best treatment, an effective treatment, until penicillin came along in the 1940s. And that was an amazing phenomena, that this antibiotic from a mold was a better magic bullet than the target. But the concept of magic bullet is, of course, with us today in all forms of particularly cancer chemotherapy. So the road isn't always straight. There's an interesting sidetrack here. Another Nobel Prize in 1927 was given to a German scientist who took people with central nervous system syphilis. Remember, in those days, there was only mercury or arsphenamine to treat them, and it didn't do much good. But he gave them malaria, and the idea was that hypothermia was good for it. Well, it took a long time to undo that, but that's possibly not one of the great moments of the Nobel Committee. So what's the point of this? What am I trying to get at? These diseases change. Even in one lifetime, they change in terms of the way they appear in patients. The organism's changing, the hosts are changing, the environment is changing. And the level of education and sophistication in dealing with them on a public health level goes up and goes down, and with overcrowding and greater populations and poverty and everything else thrown in, we now have epidemics. And so one of the themes we'll hear discussed today is why sexually transmitted diseases, I would argue, are amongst the great neglected diseases and are epidemic in our population, but we are blinded by, on one hand, the tremendous need to do things in other diseases that more classically are epidemic and lethal, and other by some of our social, political, and other concepts which tie our hands. And that there are new treatments that are directed in entirely different directions, which you will hear about. Treatments called vaccines. So we are really absolutely delighted that our two speakers, Tom Quinn and Jeff Cohen, who are leaders in this broad field, have been willing to come and speak with us. Now let me tell you a word. Thomas Quinn, whom I just met, is a senior investigator and head of the section on international HIV/AIDS research of the Laboratory of Immunoregulation at the NIH at AID. He's also the Associate Director for International Research for the Division of Intramural Research at NIAID. And for 3 decades, he's been a professor of medicine and pathology at Hopkins and in the departments of international health, epidemiology, immunology, and molecular biology, et cetera, et cetera, et cetera. Now, the important point of all this, that he's been involved in classical studies, the classical studies of HIV, clinical and epidemiologic investigations in 29 countries all around the world. He's involved extensive collaborations and developments which have influenced our entire thinking about the natural history of these diseases and the problems that are involved in trying to deal with them. So we're very grateful to you for being willing to come. And our second speaker, Jeff Cohen, who is known to our group because he kindly spoke earlier in this series. Jeff, excuse me, got his medical degree at Johns Hopkins, interned at Duke, spent time in Boston, receiving more training in clinical training in infectious diseases, was a research fellow in medicine and microbiology, came to the NIH in 1990, and is the chief of the Laboratory of Infectious Diseases at the NIH. Of his many contributions, the now classical studies on herpes viruses and means to protect against them are one of the really hallmarks in modern infectious disease. So we're very grateful to both of you for being kind enough to come and speak to us. I think, yeah.
Thank you very much for that kind introduction, and it is a pleasure to be here. In thinking about the topic, sexually transmitted diseases, I have to totally agree this is one of the great neglected diseases of mankind and has been neglected primarily because of the stigmatizing effect. In fact, for years, most of you know, it was called venereal diseases. And there was a certain stigma that was attached to that. And it's really only been in the last 3 decades that that has shifted over to more modern terminology of sexually transmitted diseases, or STDs for short. But the IOM took this up about a decade ago, and there's a report on it from the Institute of Medicine, and they entitled it The Hidden Epidemic. Because so many people, as you will see, become infected with these diseases and are unaware that they're infected. They're not screened for it, and they unknowingly and unwittingly transmit it to their loved ones or their sexual partners over a period of time. And the amount of morbidity, if one was to put economic labels on this, are truly astronomical, and it sort of defines public health today, that we really still, in 2013, are not really confronting these diseases. And I'd like to take my time to actually impress upon you about these continuing epidemics, that they are not going away, they are persisting. They are aiding in the spread of HIV, which does get a lot of attention and gets a lot of funding, and they cause a considerable amount of morbidity associated with these diseases. So I thought I'd start with a case. This is a case that I saw about 25 years ago, but it really drives a certain point immediately home. So I went to Johns Hopkins, and I was working with the STD clinics in Baltimore City. We were screening for chlamydia, and we were confronted with this case. It was an 18-year-old young girl presented with lower abdominal pain, fever, chills, and she denied any other symptoms. She was in a monogamous relationship with a male partner who she'd been with for 6 months. She was febrile, 39.3. Blood pressure was normal, heart rate was tachycardic, and had a respiratory rate of 20. Now, on examination is where most of the signs were prominent. As you palpated her abdomen, on deep palpation, she had excruciating pain, and on pelvic examination, she had extensive cervical motion tenderness. It was really quite painful. And speculum exam revealed an inflamed cervix with a mucus discharge from cervical os. We suspected that she had an intra-abdominal infection going on, and ordered an ultrasound at the time. That abdominal ultrasound showed multiple air fluid levels and consistent with a tubo-ovarian abscess. She actually was admitted, put on antibiotics. The abscesses continued, and the obstetrician gynecologist was concerned that they could rupture and cause sepsis immediately, and so took her to the emergency room. She ended up at age 18 having a full hysterectomy, bilateral salpingo-oophorectomy, and was permanently infertile for the rest of her life. That's 18 years of age. That is one of the severe consequences one can see. And so it raises the question, how can this happen? Well, it turns out we were able to determine this through the pathologic examination, but this is a specialized photograph looking in the fallopian tube of another woman who had been infected with chlamydia trachomatis. Chlamydia is a silent infection in most men and women, but like Mycobacterium tuberculosis, it's an obligate intracellular organism that the body tries to wall off and induces fibrous adhesions within the areas in which it's infecting. So in this woman, what you're looking at are these fibrous adhesions within the fallopian tube itself. If it starts to occlude, then anaerobes start to grow because of the lower oxygen tension, and you start to get abscesses that are filled with Bacteroides fragilis and other anaerobes that, if they rupture, will cause, in fact, sepsis. All of this is 100% preventable and treatable if caught early. If not screened and not treated, women in particular, but men as well, will suffer the consequences of these adhesions and suffer chronic pelvic pain, infertility, and other consequences. So we nicknamed this pelvic inflammatory disease, or PID. By definition, it's inflammation of the upper genital tract. It includes endometritis, salpingitis, tubo-ovarian abscesses like the patient I presented, and a pelvic peritonitis. The STDs that can cause this are not limited to just one organism. So it could be Chlamydia trachomatis, the most common bacterial STD in the United States, or it could be caused by gonorrhea, could be caused by Gardnerella vaginalis, Mycoplasma hominis or genitalium, and ureaplasma. And then with the adhesions, you start to see the anaerobes and enteric gram-negative rods. So if you're going to treat it, you actually have to use multiple antibiotics. It is the one time that one antibiotic is not going to work for a woman who presents with this. This is a surprising statistic to most people. It is by far the most common cause of a gynecological visit to the emergency room throughout the entire United States. So a woman who presents with lower abdominal pain gets classified in this. And if she is sexually active and could have been exposed to one of these STDs, that it's almost mandatory that she be screened for it. And unfortunately, it is the young adolescents and young adults that are at greatest risk. More than 50% of all these cases occur in women under 50 years of age. So let's take a step back. This was somewhat of an extreme case, but I wanted to drive home the importance of these diseases and the consequences in which they occur. Now, the World Health Organization has a branch that tries to estimate how common are these diseases. So they picked 4 and tried to do a worldwide estimate of these. Now, in this terminology, it's STIs, sexually transmitted infections. We use these interchangeably with STDs. But there's 4 that we could diagnose quite easily and treat and prevent the adverse reactions that individuals have. The first is chlamydia trachomatis, 105 million new cases a year. That's incidence, 105. Gonorrhea, about the same number. They estimate 106 cases. Syphilis, which we just heard about, which has been around for eons, forever, we're at a level of about 10 million new cases every year. And a very common cause of vaginitis in women, Trichomonas vaginalis, which is sexually transmitted. We estimate 276 million new cases a year. So these are truly neglected in the sense, starting off from the earlier comments, and easily diagnosable and treatable if we put enough attention to that. So let's turn our attention to our own domestic situation. Why did the Institute of Medicine call this the hidden epidemic? It's pretty much reflected here. So where is all the attention being focused today? It's HIV. And it's deservedly so, because it's a fatal infection without treatment. But now we can keep this from being a fatal disease and it causing a lifelong infection. But we estimate about 56,000 new cases occurring every year in the U.S. Syphilis, we're still seeing about 32,000 new cases, and I'll show you some of that epidemiology. But if you start to go down to the base of the pyramid, it's trichomoniasis, which women suffer the most consequence, about 7 million new cases a year. Human papillomavirus, to which we have a vaccine that's wholly preventative, but yet we estimate 6.2 million new cases a year. Herpes, which you're going to hear from Dr. Cohen, 1.5 estimated new cases a year. And then, of course, chlamydia, which is a reportable disease in the U.S. It is the #1 reportable disease in the U.S. in terms of absolute numbers. You know, we're focused on flu, we're focused on HIV, we focus on hepatitis and other infections. If you look at notifiable diseases in the U.S., the #1 reportable disease is actually a sexually transmitted disease of chlamydia. Gonorrhea estimated at about 700,000. Hepatitis B, to which we have a very effective vaccine, we still see 73,000 new cases a year, again, acquired sexually. So if you add those together, we see about 19 million to 20 million new STDs occurring in our country each year. More than half of those are in people under 25 years of age. It affects the poor or the lower socioeconomic status the greatest, and so it's now ranked as probably the #1 or 2 health disparity issue, with rates often 10 times higher in African Americans than in whites. STDs increase the risk of acquiring HIV, and the Institute of Medicine tried to put an economic number on it so as to give it some meat to Congress. And the number they come up with, not me, but they are coming up with these estimates, is about $17 billion a year in treatment or adverse complications. This is not including screening. A few more facts about these STDs as they affect the U.S. First of all, they occur in both men and women, and they are one of the leading causes of tubal factor infertility. And that's about 14% of all couples in the U.S. have tubal factor infertility, probably related to an STD that they acquired at some time in their life. 5.5 million, 5.6 million people infected with HPV each year, but because that can be a lifelong infection, it's estimated that it could be as high as 20 million people carrying HPV, and I'm going to show you some statistics on that. HPV is of serious concern because there are several types that actually cause 80% of all cervical cancers, the number 1 or number 2 malignancy facing women worldwide. And in the U.S., about 14,000 cases occur each year, and yet we have a FDA licensed approved vaccine which was developed here at the NIH. So let's take a step back and schematically look at the world of STDs. So you have an individual, they get an infection from another partner. If it's a woman, the worry is that that infection will migrate to the upper genital tract. We call that upper tract infection, which can lead to that tubal factor infertility. It can cause, with those fibrous adhesions, ectopic pregnancy, chronic pelvic pain, and other severe consequences for those women. If the woman becomes pregnant or it spreads to the fetus or at time of delivery, it can result in spontaneous abortion or a low birth weight. It has been shown a number of these infections, particularly syphilis, actually, and the genital ulcers, herpes in particular, can serve as a syndemic, is what we call it. But converging epidemics, the epidemic of HIV and the epidemic of herpes, seem to emphasize spread of both of those infections together. Of course, if a woman is carrying chlamydia infection or herpes at the time that she delivers, those infections will be delivered directly to their infant at time of delivery. And of course, I mentioned the HPV causing cervical cancers. So these are not just infections that cause a discomfortable burning on urination or a little drip, as we used to call it. These are very serious infections if not dealt with appropriately. Let me start with a few of them. I started with that PID case. The leading cause of PID is usually chlamydia. And as I showed on that earlier slide, there's about 105 million new cases of chlamydia a year. 3.5 million of those are in the U.S. It is the most frequently reported notifiable disease in the U.S. We've done studies with partners of these individuals who have chlamydia. We've treated them, and then we brought in their partner, and more than 50 to 60% of the partners will be positive. And very high perinatal transmission rates. In fact, every single baby in the United States, when it's born, gets eye drops to prevent the congenital ocular infection of chlamydia and gonorrhea that could be acquired. But it's better to screen the woman when she's pregnant before she delivers, because this is a very easily treatable disease. So we really mandate that occur. Of course, untreated infections that aren't screened for and aren't treated go on to cause these more serious diseases. We do not have a vaccine currently to prevent chlamydia. It is one that the NIAID is working very hard at. Harlan Caldwell within the Rocky Mountain Laboratories has a prototype. And there is hope for the horizon that we will eventually develop one. So what's it look like in the U.S.? Are we beating this infection? And if you look at this from 1991 to 2011, it doesn't look too good. In fact, it's on the rise. Hence, the hidden epidemic. It just is not getting the attention that it deserves to get. You might see it's higher in women than it is in men, and you can see that on this particular graphic. If we look at a case rate per age group, and the age group being shown right here, 15 to 19-year-old girls, 20 to 24-year-old young women. Look at these case rates. These are astounding. This is per 100,000 population. And then it does drop off, which we think is a reflection of acquired immunity ultimately. But some people say it's a change in sexual behavior. Regardless of what is causing this, it is probably equally high in men. It's just that men don't tend to seek health care and don't get screened, whereas women, we now have strong recommendations that every woman within this age group get screened twice a year for chlamydia. And if they are positive, because it's a notifiable disease, it gets reported. Now, there's a big difference, again, when I mentioned the disparities issue. Look at the rates in African Americans versus the other ethnicities. And part of that, I could show this by socioeconomic status or urban living, and you'd see sort of the same dramatic rate. But that's the epidemiology. The life cycle of chlamydia is absolutely fascinating. For years, everyone thought this was a virus. It isn't. It's a bacterium. And it starts out with these elementary bodies which attach to columnar epithelium, which line the cervix or the urethra. They go inside these phagosomes, resist lysosomal fusion, and actually start to go through binary fission, and over a 48-hour period, repeat the cycle over and over. It is this antigenic release of the daughter elementary bodies that stimulates the inflammatory response. But it's a very indolent type of infection, and so many people remain asymptomatic with these infections. It is somewhat different than gonorrhea in that sense. About 80% of men infected with chlamydia will be asymptomatic. The other 20% will develop urethritis, and some of those go on to developing epididymitis. And that will cause a problem for sterility. Men who have sex with men get involved with chlamydia involving the rectum, and they develop proctitis. If there's auto-inoculation of the infected secretions, it can cause conjunctivitis. If people engage in oral sex, they can get pharyngitis. And then there's an immune reaction that can occur in a very small percent of individuals who are HLA-B27 who get infected and get this reactive arthritis. Women follow the same pattern except for the complications. So about 80% are asymptomatic carriers, but 20% will develop cervicitis or a mucoid discharge from the cervix. They will also develop signs of a urinary tract infection, but the cultures will be negative for bacteria because you need tissue culture to actually grow it, but we now have nucleic acid amplified tests to pick it up. The complication we've already talked about, PID, Bartholinitis, proctitis, rectal intercourse, conjunctivitis, and again, the reactive arthritis of Raynaud's syndrome that we see. So the U.S. Task Force on Preventive Services for the U.S. came out with recommendations in 2007. They have not changed. And so I thought I'd show you what we're supposed to be doing for screening for chlamydia. Every woman who presents with cervicitis or PID needs to be tested for chlamydia. All sexually active women under 25 years of age should be screened at least once a year. Annual testing for chlamydia of all women, regardless of age, who are at risk. And they define at risk as either having prior chlamydia or any other STI, inconsistent condom use, new or multiple partners, or exchanging sex for money or drugs. It's a somewhat liberal definition of what we call at risk. So it's easy to treat. That's why it's so important that we screen for it. And we can screen urine or a vaginal swab, or on pelvic exam, a cervical swab, and have an answer within a couple hours. If they're positive, single-dose azithromycin is highly efficacious, about 95% efficacious rate. Doxycycline's about 100% effective, but the problem is compliance here. They need to take it twice a day for 7 days. The reason for that is always a half-life issue of the drugs, because remember, the life cycle of chlamydia is 48 hours, so it has to go through a couple life cycles to actually be killed by the antibiotic. The reason azithromycin on single dose works is because it has such a long, long half-life. If they have what are called the L1 to L3 serotypes, or lymphogranuloma venereum, we treat them for a longer period of time, up to 3 weeks. Even the azithromycin is given for 3 weeks. You know, we don't really recommend to test a cure, but if they come back within 3 to 4 weeks, we could do repeat testing. But rather, we strongly encourage our clinical providers to retest all women when they next seek medical care within the 3 to 12 months. Reinfection rates are extremely high with chlamydia, mainly because their sex partner is not getting treated. So the people in Seattle have, and the state of Washington has adopted this. It is not legal in Maryland, but it is in Baltimore. Go figure. We can actually give treatment to the infected person that we see in the office and give her or him an extra dose to give to their partner. They don't need to come in. So that's allowed now in several states, except, I will tell you, state of Maryland, District of Columbia don't allow this yet. But Baltimore got an exception because our rates are so high. I actually think if you saw the District of Columbia rates, you would think it should be done there as well. This is very, very important, and just recently showed how it can be utilized to lower the partner rates of infection very effectively. I just thought, I don't know how many clinicians are in the room here, but since I presented a case of PID, I thought I would share with you that the treatment for PID is much more complicated because we have to treat the anaerobes. There might be gonorrhea there. We need to treat that, and we need to treat the chlamydia. So we're treating a multitude of organisms, and so it requires that we use intramuscular treatment or even IV treatment for these women, because this can be life-threatening and it can cause sterility in these women. So very, very important that they get appropriately treated. And again, all their sex partners need to be treated as well. Let me present a second case that I actually saw when I was an infectious disease fellow out in Seattle. And actually, we published this in the New England Journal of Medicine because it was so unique. It was an HIV-infected gay man. He actually had a diagnosis of AIDS back then. We didn't know it was HIV positive, but he was 23-year-old, and he came in with severe rectal pain, and he admitted to receptive anal sex and oral sex. On physical exam, he had no oral lesions, but had exquisite tenderness on a rectal exam, and anoscopy actually visualized severe inflammatory proctocolitis. Interestingly, that individual was also infected with chlamydia trachomatis of the rectum, but it was of this form called the lymphogranuloma venereum form, which is highly invasive and actually mimics Crohn's disease. And this individual, who had been seen by a gastroenterologist, was treating him with steroids for Crohn's disease at the time. But fortunately, we were able to make the diagnosis. We then did a series study and identified 13 cases within 4 months of this. So it was epidemic at the time. There are other causes of proctocolitis besides these STDs, and so you always have to rule out the other bacterial causes and even viral causes in these individuals. that could be sexually transmitted or could be a part of their immunosuppression. So we serotype these organisms. They're called L1 or L2 or L3. They can present with inguinal lymphadenopathy, what's called the groove sign. Rectal exposure does lead to this severe proctocolitis. If you biopsy it, they actually have granulomas, identical with Crohn's disease. And again, I mentioned that we need to treat for 3 weeks for these individuals. Going to shift to another STD for a minute, or a couple minutes, because this is now a huge public health threat to our nation and to the world. This is a 22-year-old commercial sex worker who presented with 1 week of treatment of gonococcal cervicitis, presented in the Baltimore STD clinics. NATs are nucleic acid amplified tests, or PCR, if you will, or some of the other ones that we use, very rapid tests. Her symptoms did not get better after she was treated with Cefixime. She had a history of seven sex partners since her last visit, and on exam she did have a purulent discharge coming from the cervical os, and she was still positive for gonorrhea. So our debate was, did she fail the Cefixime or did she go out and get reinfected? We took the isolate, and were able to show that it was in fact resistant to Cefixime, which is an oral dose that was the standard for treatment for gonorrhea. So what is the situation of gonorrhea in the U.S.? We have a case rate in the U.S. that's the highest of any industrialized country, 50 times higher than Sweden, 8 times higher than our neighbor Canada. We did see a decline in down towards 1996, but now has been level for the last 15 years, and in fact is doubling in men who have sex with men, and we're starting to see more drug resistance. This is the epidemic curve of gonorrhea, and it's always fascinating to look at this. Here's 1941, we're in the middle of World War II, and you can see the rates were coming up, and then all of a sudden it sharply declines. That's penicillin. That was the advent of penicillin. So who got penicillin? They actually made specific guidelines that the military were the first to get it after the congressmen needed it. And it did start to come down, but didn't go any lower than what it was before. And then it became epidemic during the love years, if you will, free sex, free love, and so forth. And you can see it became really extremely high rates, 500 per 100,000 population. But then we mounted public health efforts to screen everyone for gonorrhea and get them treated. And you can see we did succeed, but then since 96, it's really been level. And if you start to look at, again, here are the women, here are the men, their case rates. It's a little bit more equal here. Still women slightly higher. But what's fascinating is when you go in to look at antibiotic resistance, and this is looking at ciprofloxacin resistance, which was a standard for a while. Now recommendations say do not use the fluoroquinolones. You can see there was full susceptibility to fluoroquinolones up until 2000. And then the resistance started going up quite dramatically and has remained up. But when you look at the population in which it got resistant, it was men who had sex with men instead of men who had sex with women. So it happened to be because we were using this antibiotic more frequently in MSM because of other problems, and the gonorrhea developed resistance. Again, high disparities resulting in these individuals. And this, again, reflects the opening remarks that Irwin talked about, and that is these bugs keep generating resistance. And now gonorrhea is now classified as a superbug in terms of resistance, much like multiple drug-resistant TB. So first it developed resistance in the 40s to sulfonamides. In the 50s, it developed resistance to penicillin. In the 60s, developed resistance to tetracyclines. You saw the data on the fluoroquinolones. And now Unfortunately, it's developing resistance to azithromycin and the cephalosporins. It's no matter, whenever we get a new antibiotic, within about a decade, it develops resistance. And that's what is shown in this particular article. If you're interested, it is a very interesting historical article showing that the gonococcus of all of the STDs is one of the brightest bugs in terms of how to acquire resistance. We now see azithromycin resistance in San Diego and Hawaii. Those have been reported. Cephalosporin resistance in Japan, Norway, Canada. In the U.S., this is showing, again, the development of resistance both to cefixime and ceftriaxone. Again, MSM is the group that we worry about the most because that's where the resistance appears to be showing up. And Baltimore, the case that I was discussing in November, was our very first cephalosporin-resistant strain. These are the MICs and the MBCs. It's still sensitive to ceftriaxone, but the oral drugs we can no longer use. And we were able to treat her with IM treatment. It's a chromosomal-mediated, plasmid-transmitted resistance. There's multiple regions on the chromosome of the gonococcus that encodes for the resistance. We don't have time to go through them all, but a fascinating story of how this organism can actually pick up these resistant plasmids and then pass it on to the chromosomes to develop resistance. So brand new guidelines for treatment of gonorrhea that we need to follow. First line treatment now is a 2-drug regimen. So you don't treat gonorrhea with one drug anymore. Got to use 2 drugs, ceftriaxone and azithromycin. Doesn't matter whether you got chlamydia or not. So a 2-drug regimen. The alternate would be cefixime, but we don't recommend that you use that because we've seen resistance now. If you see cefixime treatment, then you have to go through a very stepwise algorithm using ceftriaxone and 2 grams of azithromycin. And let me tell you, 2 grams is a lot to take. The GI side effect from 2 grams is about 20 to 30%. They vomit it right back up. So we need to be very careful now in terms of treatment of that organism. I'm going to close out with the genital ulcer diseases leading up to Dr. Cohen's presentation, which will focus solely on herpes simplex virus, which is one of the very most common genital transmitted viruses. So let me just mention that when a person presents with a genital ulcer, there's a differential diagnosis we all have to go through. Everyone in the clinic, clinician-wise, needs to think about, is it herpes? It's usually painful. Is it syphilis? It's usually painless, but the ulcers look slightly different. Chancroid is a little bit more painful. LGV, painless. And granuloma inguinale, very rare in the U.S., but common in India and in tropical areas. We call that donovanosis, and that can be actually quite painful. But let's start with syphilis, since this is the organism that has taught us medicine in its myriad ways. And this is the, again, going back to World War II, syphilis was epidemic at about the same rates that you were seeing with gonorrhea almost. Penicillin came along and wow, did that stuff work? And then look what happens. We really get into a situation where it starts to level off and then starts to go up in the 90s. And a lot of people ask, what is going on here? Very interesting investigations linking it to crack cocaine and the trading of sex for drugs, and commercial sex workers and MSM, not fearing AIDS, were coming down with this disease. And then we mounted public health efforts. We'll go through this cycle. We've done this with malaria. You mount a massive response. Things start to look good, like here. and then you back off. You can't back off with these diseases because everyone in normal adulthood is going to be sexually active, and these bugs are easy to transmit. This is, I find, probably the most interesting graphic that I'm showing you today. Because for the other diseases, I was showing you they were more common in women than in men. When it comes to syphilis, it's more common in men than it is in women. And that's men who have sex with men, which are at extremely high risk for getting this particular infection. So this is the men over here. This is the rates in women. And part of this is actually shown on this graphic, shown from 2007 to 2011. You can see it's going up in MSM. Why is it going up with MSM when we have an epidemic of HIV threatening the MSM population? It's called antiretroviral drug therapy. It works. It's taken the fear out of some of these individuals that put themselves back at risk. Not everyone. Can't generalize to the entire population of MSM, but the bathhouses reopened up. There's more partner linkage over the internet of anonymous donors, and you start to see the results of that. So syphilis is a marker that our efforts to control sexual behavior to limit HIV transmission is failing, because that's the group that's at highest risk. So what's it in your neighborhood? How's it look for the state of Maryland? You're in Montgomery County. I'm in Baltimore. Here we are, syphilis, primary and secondary rates, and congenital cases of malaria. So shown in the blue are the congenital cases. These are infants being born with syphilis. That's inexcusable. Every single pregnant woman with prenatal care needs to be screened, needs to be treated before she delivers her baby. We're doing that for HIV, but we seem to be forgetting the other STDs. And this shows you the rate in women. These are the congenital cases, and this is the rate in men who have sex with men, shown in the red. Well, we rank number 3 in the country as a state. Okay, 452 cases of syphilis. It's really a shame to see this. But some of you work in the District of Columbia. What's it look like there? It's worse. For the District of Columbia, it's the highest case rate of any urban center in the country, higher than any other industrialized city. It's as high as anywhere I've seen worldwide. And here it is in MSM going skyrocketing in the first decade of the 21st century. And now it's leveling off. We've got to see this coming down, or we're just failing these people. You've seen these photographs. This is a dark field with use of a monoclonal antibody, the Treponema pallidum, from a genital ulcer. That's called primary infection. Then, if not diagnosed and treated, can present as secondary infection, which is usually a skin rash in the palms and soles. And we always look for this in all of our patients. And of course, the tertiary infections we see rarely, because we're usually now do screen all individuals at some point with serologic diagnosis and try and get them treated. This is secondary syphilis, and it's, no syphilis, and you know all of medicine, is actually interesting because we actually see quite a bit of secondary syphilis in our HIV population and our men who have sex with men. You can occasionally see these oral lesions as well. So after primary and secondary, the treponeme goes into what is called the latent phase. It's still there. There's still an immune response. They usually have a positive serology. If the diagnosis was made within the first year, then it's called early latent syphilis. If they don't know when they got their primary infection, and we usually classify them in late latent. That's usually a year after, or more than a year afterwards. And interestingly, these early latent cases can relapse into secondary cases. After 4 years, that's no longer infectious, and they're more resistant to reinfection if they get treated. So it can either be asymptomatic or symptomatic. If this is in the early phases of neurologic disease, it can present as meningitis in the first year of infection, but later on, it's usually asymptomatic, but in a rare population, you see meningovascular disease or parenchymas disease. The thing to take home about this is if they're HIV infected and positive serology and are in the latent phase, we recommend you do a spinal tap to see if there's cells. We've changed the testing for syphilis. It's now done by EIA, but the EIA, which is highly sensitive, is not very specific. So just the positive EIA doesn't mean they have syphilis. You need to reflex it to a more specific treponemal test and go through a confirmatory test. And the same is true with the CSF if you do a spinal test. And then, of course, this is mandatory reporting to the state. The good news about syphilis is penicillin still works. We have to use higher doses than we did during World War II, but basically 2.4 million units of long-acting benzathine penicillin works. If they have penicillin allergy, we can treat them with doxycycline. If they have that latent syphilis, more than 1 year, then we have to treat them for a longer period of time. And if they have neurosyphilis, this benzathine penicillin doesn't get into the CSF, so now we got to go to IV. So there's multiple steps that we go through in the treatment of syphilis. I'm going to close with human papillomavirus, so we have some time to talk about herpes. And I bring this up, I only have 2 slides on this. There's more than 30 types of HPV that causes genital infection, but there are 4 actually that cause cervical cancer. But in the US, there are primarily 2, HPV type 16 and 18. But we also see 6 and 11 that's extremely common. So a vaccine was developed against these 4. It's called the quadrivalent one because these cause 70% of cervical cancer. These 2 probably cause 80% of all the benign warts. But they can go on to cause this low-grade dysplasia. The single biggest risk factor for dysplasia is persistence of the infection, and it can last for quite a long time. These are some of the risk factors, and we are concerned once again with co-infection with HIV because of the immunosuppression. This is an NHANES survey. You all know about NHANES. This is a national survey. This is the age group of people who were screened for low-risk HPV or high-risk HPV. And you can see this is extremely common for both low risk and high risk. And it was on the basis of these data that the FDA and the preventive recommendations, public health recommendations, promoted that all individuals within an age group be given the HPV vaccines. It's now approved for both girls and boys. It's highly efficacious, one of the best vaccines we have. We recommend it in 9-year-old girls to 26-year-olds, and the same for boys now. The uptake is 35% in girls. Only 35%, leaving 65% at risk for developing cervical cancer because someone didn't get them vaccinated. So as a parent, this is something I made sure my daughter got vaccinated. It is very, very efficacious. And it should be applied for boys. In Australia, 95% of all girls are vaccinated. 95%. It's truly a failure of our healthcare system that we only have a 35% uptake in women and a 5% uptake in boys. Not good signs at all. It's not therapeutic, so once you get cervical cancer, you're not going to be getting this vaccine at that point. So on to Dr. Cohen, who's going to talk about herpes. 1 in 5 adults in the U.S. has been infected with the herpes simplex virus, but only about 10% of that population who are infected are even aware that they had this virus. They cause primarily genital disease, but also oral infections, which we'll hear about, and there's intermittent asymptomatic shedding. So once infected, it's lifelong, and intermittently shedding it, even though there's no symptoms, and can infect people. The good news, as you'll hear, is that we do have very good antivirals. They're not 100% in suppression, but they're very high. And I'll let Jeff go into much more detail about these treatments. So these are the different drugs that we use, and I'll be glad maybe we'll take questions after Jeff has had a chance to talk, since I went a little bit longer. Thank you.
Okay. Thank you very much, Todd. We can have a couple of questions if you have something you would like to ask at this point. There's a microphone in the center here.
Yeah, so I just have a question about, for the slide that you have, the most common STIs, like there are 4 that you listed. I was wondering how many of them are like co-infected, because you had several of them that had over 100 million cases every year. So I was just wondering, like, those are not separate infections, right? Some of them are.
It can be counted twice.
Okay.
You mean, in other words, could a person have chlamydia and gonorrhea?
Yeah, because I think
Yes.
those numbers are quite high, right? So I
They
just
are
wonder-
high, and they're just estimates from the World Health Organization, and you can pull it up on your computer. And they tell you how they tried to get this, but yes. So there were 105 chlamydia, 106 gonorrhea, probably an overlap of about 10%, where they had both.
Okay.
And they're listed in that 105, but it's not that much higher than that.
Oh, okay. Thank you.
Yes?
Thanks a lot. I'd read a couple articles in the popular press recently about the idea that there are viruses that are kind of akin to HIV, and people who are are in places where HIV originated, they're working to sort of find what those viruses could be and fight them before they get out, so to speak. I wondered if you had any comments about that. And
So this is looking at some of the simian viruses and so forth. So some are retroviruses, some are others. There are groups working in West Africa, preferentially, is where a lot of this is being picked up. And maybe Jeff might want to address some of this as well. As far as I know, none quite fit the picture of either HIV or some of these STDs that I've been talking about. But we're continually screening and looking. There's the Department of Defense funds an initiative that is looking at the emergence of new diseases and new infections, but none that quite fit the picture of HIV at this point. Jeff,
Okay.
did you want to comment on that? No. Okay.
All right.
Great.
Thank you, Tom. We'll have time
You bet. Thank
for
you.
discussion after Dr. Cohen's.
Okay. Well, thank you. I'm going to be talking on herpes simplex virus. I'm going to show a little bit about the epidemiology of the disease, talk to you a little bit about treatment, and talk to you about the state of vaccines for herpes simplex virus. So as a disclaimer, I do have a collaborative research agreement with Sanofi Pasteur to study an HSV-2 vaccine. As Wynn mentioned and as Tom mentioned, herpes virus has been seen as was described actually in the 80s in Time magazine as a social plague, just because this virus can be transmitted to others by people who don't even know they have it. Here we have a modern day Hester Prynne and I guess Dimsdale here. So worldwide, you can see that HSV infects over 500 million persons, and in the United States, it's estimated that 50 million persons are infected with HSV. And once infected, of course, people are infected for life. You can see here in the United States, this is the seroprevalence in women. It's roughly 21 to 30%. But in other countries, particularly in areas of Africa, it's greater than 50%. In men, these rates are about 5% higher. And as Tom mentioned, most individuals infected with HSV-2 are asymptomatic or the infection is unrecognized. So these are seroprevalence rates from the CDC for HSV-2. What you see here again, certain ethnic groups, particularly black, non-Hispanics, have much higher rates of HSV-2 than other ethnic groups. And you can see here also that individuals that are 14 to 19 years old have relatively low rates of HSV-2, but these rapidly increase as individuals get older. So this is important in terms of who we would vaccinate with an HSV-2 vaccine. And we really think about targeting the same groups that actually get the HPV vaccine. Now, genital herpes was initially thought to be predominantly HSV-2, and more recent studies show that HSV-1 has an increasing role for genital herpes. This is a study from Madison, Wisconsin, the university there, and you can see that look at the percentage of HSV-1 as the cause of genital herpes. It was well under 50% in the early 1990s. But in both women and in men, that has increased, such that HSV-1 is the predominant cause of genital herpes in young women. This is from the year 2001. In a recent vaccine study, it was shown also that HSV-1 was the predominant cause of genital herpes. So when we think about genital herpes, we have to think about HSV-1 and HSV-2. When we think about a vaccine for genital herpes will have to protect against HSV-1 as well as HSV-2. So why do we need an HSV vaccine? To try to prevent genital herpes, and women with genital herpes can transmit the disease to the neonates, and this can be a fatal disease in the young child. It can be very difficult to treat. HSV causes severe disease in patients with AIDS and in transplant recipients. And as Tom mentioned, HSV-2 causes a threefold increased risk of acquisition of HIV, as well as an increased risk for transmitting HIV. Now, we do have some antivirals available, but an acyclovir reduces the transmission rate of HSV by 50%. I'll talk about that in a minute. But a number of studies have shown that even though you can reduce the transmission rate of HSV-2 with acyclovir, it does not affect the HIV acquisition rate in persons with herpes simplex. So antiviral therapy for HS2 is not the solution to reduce the rate of transmission of HIV. So what happens in terms of the pathogenesis? Individuals get infected with genital herpes on the mucosa in women or on the skin of the penis in men. The virus travels up the sensory nerve to the dorsal root ganglia, which is alongside the spine here. There, the virus establishes a latent infection for life. It stays there for the lifetime of the individual, and then the virus can come back down the same nerve and reactivate to cause genital herpes reactivation. And this is a very frequent, these reactivations are much more frequent than was originally thought. So this was a study done in Seattle by Larry Corey's group. And in the study, they took individuals who were generally had asymptomatic disease. These patients swabbed themselves 4 times a day, and PCR was performed to look at shedding of virus. Most of the patients were asymptomatic when the swabs were performed. And when they looked any time of the day, and you look at the number of positive swabs over the total number of swabs, 1 out of 5 swabs was positive. So 1 out of 5 times these people were shedding HSV DNA, either from the genital area or from the mouth. So this sort of changes the paradigm. We used to think that this virus was latent. One would get reactivations, 1 to 6 or 10 reactivations a year. But it turns out that people are shedding this virus quite a bit of the time. And unfortunately, even when people are asymptomatic and shedding the virus, they can transmit the virus to their partner. So HSV often does not remain latent. So if we look at the cellular level here, we can see again the virus infects the skin or the mucosa. The virus replicates inside these cells, and the virus then is transmitted to the terminal axon, where it goes up into the neuron and establishes a latent infection. the virus can then reactivate, come down the axon, and again, one can get replication here with shedding of virus. So I'm going to focus a little bit on this box right here on replication and tell us and sort of say why it's important to study this and how it teaches us about treatment of disease. Because for the treatment of genital herpes, we focus on the replication aspects of things, and we really don't have drugs to affect latency right now. So when the virus replicates, it makes 84 different proteins. These are called the immediate early proteins, which regulate expression of other viral genes. They're early proteins, which are the targets of every antiviral that we have for herpes simplex virus. And they're late proteins, which are structural components, and this is what's been the target of vaccines. So why do we study the immediate early proteins? Well, there are new compounds coming down the pike, and actually Tom Christie here at the NIH has been studying gene expression of herpes virus, and he's found new compounds that regulate expression of these immediate early proteins, and they reduce replication, and they can reduce reactivation from latency. So one of the ones that he's discovered in his laboratory, which affects the histones, which are important for controlling gene expression. If he takes mice, infects them with herpes simplex virus, the virus is latent in the ganglia. If you take the ganglia out of the mouse, the virus can replicate. If you add acyclovir to the ganglia, the virus doesn't replicate. If you remove the acyclovir, it does replicate. And with some of these newer compounds that inhibit immediate early genes, they also inhibit replication. So these are new targets, and new targets are important because the drugs that we have right now all act on the same step of the virus. These are immediate early genes. In terms of early proteins, there are a large number of them, but the ones that are particularly of interest to clinicians are the herpes simplex thymidine kinase and the herpes simplex polymerase. So the drugs that we have right now, acyclovir, for instance, gets inside of cells. When we give it to patients, the viral thymidine kinase phosphorylates and puts a single phosphate group onto the acyclovir, and then the cell puts 2 additional phosphates on so that you have the acyclovir triphosphate form. And it's only the triphosphate form of acyclovir that inhibits the viral DNA polymerase and inhibits viral replication. So these drugs are incredibly safe because they're only phosphorylated. This initial phosphorylation event only occurs inside infected cells. And as a result, acyclovir and the other drugs are quite safe. So where did anybody get the idea for giving acyclovir? And it turns out that Gertrude Elion and George Hitchens, who shared the Nobel Prize for development of acyclovir and some other drugs, basically took guanosine, which is one of the building blocks of DNA, and modified it just a bit. This guanine base is the same here, but the ribose sugar here is broken open. So this used to be called acyclic guanosine or acycloguanosine because this cyclic structure is missing, and it was renamed acyclovir. So you can see it looks just like guanosine. It gets incorporated into the DNA, and it actually inhibits the viral DNA polymerase. Now, we have other drugs, including valacyclovir, which is a more active form of acyclovir. And what was done was to take the end of this molecule and just put a valine amino acid on it. And that increases the ability of the body to absorb the drug. So valacyclovir gets absorbed much better than acyclovir. But in the intestine, the valine comes off. So what's in the bloodstream is actually acyclovir. So we get the same thing in the bloodstream, but just a higher level by giving valacyclovir. The third drug that we often use for treating herpes simplex is famciclovir. And again, this is a prodrug just like valacyclovir. It gets converted into the body into penciclovir. And you can see the penciclovir, again, has this guanine base here and has a tail coming off of it. So all 3 of these molecules are very, very similar. And by studying DNA and by studying the structure of DNA, a number of antivirals have been discovered. So what about treatment of HSV-2? So again, acyclovir, valacyclovir, or famciclovir. And we can either treat acute or recurrent disease. And if you look at the duration of symptoms of an individual without any treatment, the first episode, individuals typically have about a 12-day course of symptoms. It takes a full 20 days for the healing to occur. And with recurrences, they're usually shorter, usually about 9 days of symptoms. Now, if we give any of these 3 drugs, it reduces the time to resolution of the first episode by only about 2 days, and recurrent episodes by about 1 day. Reduces the time to healing of lesions by about 4 days or 1 day, and reduces the time of duration of shedding by 7 days or 2 days. Without treatment, there's about 12 days of shedding. So we can modify the disease in this case, and it's recommended particularly for the first episodes, which tend to be more severe, to treat with acyclovir. Recurrent episodes, as we'll talk about, the treatment can vary depending on how many recurrences people have. Now, there's also suppressive therapy, and if people have greater than 6 recurrences a year, or if they're in a relationship where their partner is not infected with herpes simplex virus, many clinicians recommend suppressive therapy, where you take one of these compounds every day. When that's done, 70 to 80% of the recipients are recurrence-free after taking the drug for 4 months. And there's an 80 to 90% reduction in the number of days with asymptomatic shedding based on culture by taking suppressive therapy. In the absence of suppressive therapy, about 38% of people will have 6 or more recurrences a year. About the mean recurrence rate is about 4 per year. This is with HSV2. With HSV1, the recurrence rates are lower. It's estimated about 1 recurrence per year with genital HSV1. So there are drugs to treat. These drugs are not cures for herpes. They do reduce symptoms. They can reduce shedding, but the herpes is still there. The late proteins, again, these are targets for antibody and vaccines. This is an electron micrograph of a herpes virus. You can see the core here that has the DNA inside of it. There's an envelope, and there are glycoproteins that stud the envelope, and many of these glycoproteins are what scientists target for development of vaccines. These glycoproteins are the major target for antibodies against herpes simplex virus, and as we'll see, they're important for the virus to attach to cells and to fuse with cells. So in terms of developing vaccines, we try to learn from nature first. And antibody is transmitted across the placenta, and antibody protects neonates from developing severe disease. So it's important, we think, to have a vaccine that would induce antibody responses. However, antibodies does not prevent recurrences, and what's more important for recurrences are T cells, another arm of the immune system, or T lymphocytes. And if you look at people who don't make antibody, or people who have T cell immunodeficiencies, it's the people with the T cell immunodeficiencies that have really severe HSV2 disease. So T cells are important for limiting the severity of the disease. And both the CD4 cells and the CD8 cells are important for limiting disease severity. So we think that both antibody and T cells would be important for a vaccine. And there's only one licensed vaccine for herpes virus, which is the chickenpox vaccine and the shingles vaccine. This is a live attenuated vaccine, and this vaccine induces both antibody and T cell immunity. So based on that paradigm, we think a herpes vaccine should induce both antibodies and T cell responses. So again, in terms of T cells, this is a slide from actually a human ganglia from a person who died, not of herpes virus, but the person had latent herpes virus in their ganglia. And the herpes virus you can see here are these black speckles here in the nucleus, which are probed with a marker to herpes virus. And what you can see here are these T cells surrounding the ganglia, which we think are poised there to try to prevent reactivation. Now, Larry Corey's group in Seattle has done a number of studies in women, and this is actually a biopsy of a genital mucosa from a woman who has herpes. And what you can see here by staining for T cells with antibody to CD8 and for staining for HSV2 using what's called tetramers, the yellow pattern here, the yellow dots here, are actually HSV-specific T cells. And they're located right in the epidermal-dermal junction here. They're poised to try to kill virus-infected cells when the virus is reactivating here. So there are lots of T cells in the genital area poised to kill the virus-infected cells, but still virus shedding occurs. So in terms of preventing HSV2, we know that condoms can reduce transmission, and we also recommend, if we want to reduce transmission, both condoms as well as consider chronic daily acyclovir. A study from the Seattle group showed that chronic daily acyclovir reduced the shedding of HSV2 DNA by 73%, and more importantly, reduced the transmission of HSV2 to susceptible partners by 50%. So you do get a reduction, but only 50%. And we think that newer drugs on top of valacyclovir might reduce this rate, but really a cure for herpes would really require a vaccine to prevent infection or prevent disease and shedding. So again, for developing a vaccine, most of the research so far has been on glycoprotein D. This is on the outside of the virus. It's the most abundant protein on virus-infected cells and on the outside of the virus. It is the major target, or I should say a major target for neutralizing antibody. It's also a target for these T cells, which are important for controlling reactivation. And it's the protein that's known to bind to receptors on the cells. So if you could block glycoprotein D binding from receptors, you could block the virus from getting into cells. So thus far, there have been 4 randomized, double-blind, placebo-controlled trials of a prophylactic herpes simplex virus vaccine for which there have been good clinical endpoints. The first of these was done in 1990. Purified glycoproteins were obtained from infected cells. They were given to one partner who's in a stable relationship with another partner who has HSV2. And unfortunately, the outcome showed no difference in the time to HSV2 acquisition, and there were relatively low levels of antibody to GD. So later on, recombinant protein, glycoprotein D, and glycoprotein B of herpes simplex virus was produced. Again, this was given to individuals who were in stable relationships or individuals in a sexually transmitted disease clinic. But unfortunately, there was no time to difference in acquisition for the endpoint of the study. But when they looked very early on in the study, there was a trend towards lower rates of HSV2 acquisition, but they didn't really hold up. 2 back-to-back papers were published in New England Journal by Larry Stanberry, looking at the same recombinant GD in a different adjuvant using alum monophospholipid A in discordant couples. The primary endpoint of the study was protection against genital herpes, and it was not met with only a 38% efficacy, but subgroup analyses were done. And it turned out when they looked at women, but not men, and when they looked at women who were HSV1 seronegative, the vaccine had a 73 to 74% efficacy for genital herpes virus disease. So because of this sub-study, the FDA requires one to do a study where the primary endpoint would be genital herpes virus disease in just these individuals. And that was the HerpiVac study. Again, the same vaccine used here, only in HSV1 seronegative women. That is the group that it looked like it worked for here. And to everyone's surprise, this vaccine in this group had only a 20% efficacy for genital herpes, which is why the FDA in their wisdom says you can't license something based on a sub-study. You have to have a primary endpoint here. So just to look at this study just a little bit more, it was just published last year, a double-blind, placebo-controlled study, phase 3 study. The NIH participated in this study. 8,000 women at 50 different sites in the United States and Canada, a really enormous study. Again, women were seronegative for both HSV1 and 2, got 3 doses of this glycoprotein D in adjuvant at 0, 1, and 6 months. The placebo group got hepatitis A vaccine. The follow-up was 20 months. The primary endpoint was genital disease, be it HSV1 or HSV2. These are the outcomes. Only 20% efficacy for genital HSV disease, which you see here. But if you look at HSV1 genital disease, there was actually a 58% reduction in HSV1 genital disease compared to the control group. But if you look at HSV2 genital disease, the vaccine actually did a little bit worse than the control group. So this is for disease. What about HSV1 infection, preventing infection? And you can see just about the same rates here. The vaccine had really very low rate for protecting against HSV infection, a little bit better for HSV1, nothing really for HSV2. They looked at shedding because if you had a vaccine to prevent a disease, but individuals still shed, that's not going to help public health because people will be going around shedding virus. And the vaccine actually did not reduce the rate of shedding of HSV. The vaccine induced antibody responses, but they fell rapidly, and by 16 months of the study, the antibody responses, the mean antibodies, were undetectable. And the vaccine induced one form of T cells, CD4 T cells, but not CD8 T cells. So this was a very humbling study. Possible reasons why it didn't work: insufficient levels of antibody to HSV glycoprotein D, lack of inducing CD8 T cells responses to herpes simplex. The only herpes protein in the vaccine was glycoprotein D, and perhaps other herpes virus proteins would have been improved the immune response. And we really don't know what the immune response was at the site of infection in the genital tract. So although they measured antibodies and T cells in the peripheral blood, what's probably more important is the antibodies and T cells at the site of infection in the genital tract. So where's the field going from here? A number of other subunit vaccines are under development. A group in Seattle is looking at multiple HSV2 peptides, short proteins of the herpes simplex virus, complex to what are called heat shock proteins in a different adjuvant. And these heat shock proteins allow this vaccine to induce both CD4 and CD8 responses, which were seen in most of these individuals in a phase 1 trial. No idea how efficacious this would be. Another group is looking at glycoprotein D and an immediate early protein in their adjuvant. And this study is just underway in clinicaltrials.gov. There's absolutely no data on it at this point. Another group has done mouse and guinea pig studies with glycoprotein D and glycoprotein C. We don't know how that's going to pan out or whether a company will take that up. DNA vaccine expressing HSV2. This induced some T cell responses in a minority of individuals in this particular study. And in animals, in mice and guinea pigs, an inactivated HSV2 in alum and PL has been tested, and it looks good, at least in animals. Now, in addition to subunit vaccines, there are live attenuated and replication defective vaccines that are under development. There's a group in Great Britain that has taken the HSV2 genome, deleted several immune evasion genes, which I'll talk about in a minute, and this virus seems to be attenuated. It doesn't inhibit the cellular immune responses. This trial is ongoing. There's no data available for it at the moment. A group in Philadelphia has deleted a single glycoprotein, glycoprotein E. The virus infects cells, but does not spread along axons. It looks promising in mouse and guinea pig models. And our group, I'm going to just briefly mention later on, has mutated glycoprotein D, and I'll talk about that in a few minutes. And there's a replication defective vaccine that's deleted for 2 essential genes that can infect cells but not spread. So in terms of this replication defective vaccine, because that's probably sort of next on the clinical trial list, David Knipe at Harvard deleted 2 essential genes in herpes simplex virus, UL5 and UL29, which are required for the virus to grow. So if you take this virus, which lacks these 2 essential genes, you can grow the virus in a cell that expresses UL5 and UL29. The virus grows perfectly fine, virus comes out of the cell, and that virus can infect normal cells, but when it infects normal cells that don't have UL5 and UL29, the virus makes immediate early and late proteins, but the virus DNA can't replicate, so no virus is produced. But this normal cell will make most of the immunogenic proteins of the virus. Excuse me. So why might this vaccine be more effective than glycoprotein D? Well, it should induce CD8 T cells more effectively. It presents nearly all the viral antigens to the immune system. And the glycoprotein D that's being expressed is being expressed with the other proteins in the membrane of the cell. And as a result, it may be in a more physiologic conformation than just the soluble glycoprotein D that may fold differently. However, this virus still encodes these immune evasion genes that inhibit the immune response. And herpes simplex virus is a difficult virus for a vaccine. It encodes a protein that downregulates class 1 molecules that block cellular immunity, encodes a protein that blocks antibody responses, encodes a protein that blocks complement responses. So these viral proteins which block the immune system are still in this vaccine. So how do we test herpes vaccines in the laboratory? We test them in mice and in guinea pigs. In the mouse model and the guinea pig model, we can tell whether the vaccine can prevent primary disease, whether the vaccine can reduce shedding, reduce latent infections, whether the vaccines can induce antibody responses. We use mice because we have reagents to look at T-cell responses in mice, and we use guinea pigs because, unlike mice, guinea pigs undergo spontaneous recurrences of herpes simplex. So this is just a slide from a paper that we wrote a few years ago where we compared glycoprotein D vaccine in alum NPL as well as a more potent adjuvant with DL529. And what you can see is the guinea pigs that got the DL529 vaccine in these open triangles had less shedding of virus after challenge. So the animals get the different groups of the animals get a different vaccine, and the animals are challenged intravaginally with HSV2. So you see decreased shedding of the challenge virus. You see decreased lesion scores in these animals because the guinea pigs do get genital lesions. We see decreased number of recurrences with DL529 versus glycoprotein D. And if we look at latent virus in the dorsal root ganglia of the animals, we see less latent virus in the animals that got DL529 versus glycoprotein D. So at least in the guinea pig, it looks like this vaccine may be more effective than glycoprotein D. So in conclusion, compared to glycoprotein D, animal vaccination with DL529 induces, I didn't have time to show you, higher levels of neutralizing antibody, reduced shedding, higher levels of CD8 T-cell responses, and it tends to reduce both acute and disease as well as the number of recurrences. So a company right now is currently making this vaccine for a phase 1 clinical study in humans. So we are also in our laboratory looking at a replication competent vaccine because we think this might even be better than a replication defective vaccine. Again, recall that the only vaccine that works for herpes virus is the shingles and varicella vaccines, and these vaccines are live attenuated vaccines. So we're interested in making a live attenuated vaccine. And what we've done is to try to engineer a virus that can grow in epithelial cells but not in neurons. So the idea, you've seen this before, is we have a virus, if it replicates in the epithelial cells and can induce a good immune response but not get transferred to the neuron, gets blocked at this stage, it can induce a latent infection and shouldn't reactivate. So you should get the immune response, an initial potential rash, but then it would be all over at that point. So we've taken advantage of the fact that glycoprotein D is the major glycoprotein that's important for binding to receptors. One of the receptors is Nectin-1 on epithelial cells and neurons, and glycoprotein D also binds to another receptor called herpes virus enteromediator on epithelial cells and lymphocytes. And these binding to receptors are essential for the virus to infect cells. And what's been known now by crystallography is if you look at the structure of Nectin-1 complex to herpes simplex virus glycoprotein D, there's an interface here where Nectin-1 binds to glycoprotein D. This is magnified here. And what you can see, there are certain amino acids, which are these letters here, that are important for glycoprotein D to interact with Nectin-1. 3 of which are shown in boxes here, an aspartic acid, an arginine, and a phenylalanine. And what we've done is to mutate each of these 3 amino acids with the idea that HSV, if we mutated these amino acids, it should not be able to bind to Nectin-1, which has been shown by other individuals, but we've made a recombinant virus that has mutations in the amino acids, so it shouldn't be able to bind to Nectin-1 and shouldn't be able to enter through Nectin-1. So just to go through this again, different receptors are needed for binding to different cell types. These are the 3 amino acids I showed you. We made a virus that has these 3 amino acids changed because of changing the nucleotide sequence here. It can't bind to Nectin-1, so the virus can still enter lymphocytes, can still enter epithelial cells, but neurons are thought to only use Nectin-1, so the virus shouldn't bind to neurons and shouldn't be able to enter neurons. So here we've taken cells in culture, epithelial cells, neuronal cells, infected them with wild-type virus, and you can see the virus replicates to high titers in those cells, infected them with our GD mutant, and it infects epithelial cells just fine, but doesn't infect neuronal cells in culture. And if we just change those 3 amino acids back, the virus grows perfectly fine. This is in cell culture. What about in animals? So in mice, if we infect the mice intramuscularly with wild-type virus, the ganglia become infected with herpes simplex virus. But if we infect with 10 times the dose of our mutant virus, the ganglia don't seem to get infected at all. So we've just done some preliminary experiments immunizing mice either intramuscularly or actually intranasally with our vaccine virus, or a mock immunization, and then challenge the animals with very high doses of wild-type virus. And you can see the animals that get the vaccine are protected, whereas the animals that got the mock vaccination all died. So the last slide, just to conclude, studies of HSV2 proteins, I think, are very important for developing new antivirals to treat both acute disease and hopefully to reduce reactivation and, importantly, better reduce shedding. And while an HSV2 vaccine is not currently available, we think that new approaches to vaccine development beyond the soluble glycoprotein D are promising. So on this late note, I'm going to stop there and see if we have time for questions. And sorry, these are the members of my laboratory group that have been working on the HSV vaccine. And Steve Strauss, the late Steve Strauss, piloted these studies, and David Knipe developed the DL529 vaccine. So we'll stop there.
Fine, thank you very much. That was wonderful. Please, if you have questions, go to the microphone. So how long do you think it will take to evaluate the current vaccine that you're working on? Like, just so we get an appreciation.
Yeah, well, I can tell you that we have, so since DL529 was first developed in the laboratory, in David Knipe's laboratory, it's taken literally a decade for us to get and it's not because we're really all that lazy, but it's been taking a decade just to get an industrial partner on board to commit to the millions of dollars it takes to make a GMP-grade vaccine. Now, we hope to be doing a phase 1 study. Hopefully a phase 1 study will be done of this vaccine in the near future. And from there you could see the HerpesVac study was basically a decade from the time that GD was first put into humans to get to a phase 3 licensable study. So these studies take really a long period of time. So I would say, it's still a decade off, unfortunately. And part of that is just because, again, as Tom has mentioned, the public doesn't perceive a tremendous need for a vaccine. So you can see what's happened with HIV vaccines, which has been taken a while to undergo, but finally we're getting some vaccines in the pipeline. HSV is much slower.
Do you have any questions or comments about this? Do you think that I'm sort of curious, where do you think we will be at 5 years from now in the treatment of sexually transmitted diseases?
So I'll just mention,
are there reasons for brightness on the horizon, or are we going to be?
There are some new
over the
antivirals for HSV which work at a completely different step than what I showed you, and many of us think if you combine a new antiviral with the current antivirals, you could potentially reduce shedding by another 50% or even more, and potentially that could help to reduce the spread of herpes simplex virus. But in terms of taking someone who's already infected and avoiding and curing them from HSV and having absolutely no virus in them, I think we're a long ways off. Tom can talk about some of the other.
Yeah. So if you look back over the last decade and a half, it's been revolutionary in terms of using molecular diagnostics to identify those people who are infected. And I would say within the next few years, we will have point-of-care diagnostics for the vast majority of these STDs. So you can come to the clinic, and before you leave the clinic, you'll be told whether you've got chlamydia, gonorrhea, herpes, hepatitis C, et cetera, et cetera. And I actually think early diagnosis and trying to get that part of mainstream medical care could really make a major advance in limiting the spread of these diseases. We're not there yet, but I think we will. In terms of effective drugs. The bug I worry about is gonorrhea. I do think resistance is going to continue to grow. Most of that resistance doesn't come from the U.S. It comes from other countries where the antibiotics are unregulated. And we're starting to see that with malaria. We see it with tuberculosis. I think we're going to see this with gonorrhea and some of the others. So I worry about that. I hope we don't go down that road. But I can tell you at most of the STD meetings, there is, session after session after session is about gonococcal resistance to antibiotics. So.
May I ask a question? What is known about the transport mechanism for the virus up and down the axon?
Yeah, good.
Not a whole lot is known. It's thought that the virus, so how the virus is transported along the axon. So it's clear, it's pretty clear that the envelope of the virus comes off. Nucleocapsids are transported up along the axon using the same sort of molecular machinery that these neurons use to transport things. It's a saltatory effect where when people label the virus with green fluorescent protein, you don't see sort of a gradual transport. It goes in sputters and stuff along the pathway, but it's using the same molecular machinery that the cell uses to transport. And there's really, that's something else that one could potentially block, but the problem is you'd need something specific for the virus and that wouldn't interfere with transmission of signals in the neurons.
So I'm curious, I haven't gotten married lately, but when I did, you had to have a blood test for syphilis. Does that still exist, or are there any premarital tests that are required by law?
Not that I'm aware of. Not that I'm aware of. They tried to do that for HIV for a while, and it didn't get implemented because they said it was too costly. So they always analyze cost effectiveness before they implement one of these public health policies. Syphilis, which is the one you referred to, once those rates came down, yes, it's very level and low. I mean, it's still bad in the district and a few others. It's an MSM. It's in different populations. So to mandate it for everyone, which is what you'd have to do, would not be cost effective. And that's why the policymakers don't implement that. Interesting. Okay, well, listen, thank you both very, very much. It was very exciting. We appreciate your being here. By the way, next week we go back to Building 50. This was an exception today of being over here.